Hi there, I'm Dr. Andy Northcott from the Geller Institute of Ageing and Memory, and I'm here to talk you through our paper Pad Cultures and Their Consequences, which will give us the findings from an ethnographic study looking at continence care for people living with dementia during a hospital admission. So this project was funded by the NIHR HS&DR programme. There were no conflicts of interest related to this study, and the views expressed are those of the authors and not necessarily those of the NHS, the NIHR or the Department of Health. Today we're going to talk about hospital care for people living with dementia. Now, people living with dementia are now the single largest group of patients by condition within NHS hospitals, taking up over 9 million bed days per year. And as more people living with dementia are going into hospital, where they tend to stay for longer than patients admitted without dementia, it's unfortunately associated with a much higher risk of poor outcomes than with a general patient population. There's a much higher short-term mortality and twice the risk of dying compared to patients admitted without dementia for the same admitted condition. Now, the vulnerability of this group within this setting and the poor outcomes associated with it are not unknown. The NHS has made many efforts to respond to this. They've created new types of wards, such as care of the elderly. There's things like RAID teams, rapid assessment, interface and discharge, to try and minimise the amount of time people are in hospitals. There's greater awareness of cognitive impairment and of frailty. There's more and more specialist teams and skills and dementia champions, admiral nurses, and attempts to identify and be aware of dementia. So the picture shows a board that's typical in pretty much any hospital ward, the dementia-friendly board, and you get these things like blue flowers, blue butterflies, forget-me-nots. You'll see things like "this is me" forms at the foot of a bed to try and tell staff about the person there. But what we found in our research is this is often window dressing. It shows a willingness to try and improve care for people living with dementia during a hospital admission, but there are still many aspects of everyday care and the cultures of care that drive them that are failing to meet the needs of people living with dementia. Today I'm going to talk you through, very briefly because of the time limit, the findings of one part of a hospital ethnography that I've been doing with Professor Katie Featherstone. It's part of a wider project of ethnography we've been doing since 2015 on this area. And this one specifically looks at continence care, which is one of the most hidden and it's one of those things we don't like talking about, going to the toilet, so we don't. So continence care for people living with dementia in hospitals is really underexplored in the literature. And we tried to address that with an ethnography where we spent 180 shifts, anywhere from 2 hours to 6 hours on each shift, over a 12-month period, looking at continence care, not going behind the curtain. We weren't following people into the toilets. We were watching nursing staff and healthcare assistants as they went about delivering everyday care to people and looking at how continence care factored into that. When people were going to the toilet, how they were going to the toilet, what support was offered. We did this at 6 wards in 3 hospitals across England and Wales, recruiting 108 participants. And on top of observations, we carried out 562 ethnographic interviews as we observed care. And it's important to stress that people living with dementia were involved at every stage of this project. They were co-applicants on the study. They helped in the design of the protocol. They assisted us with the research governance and the drawing up of all public-facing documents. They were involved in meetings as we did ongoing analysis of our findings and with the programme of dissemination that I'll discuss at the end of this presentation. So, the dreaded part of any qualitative presentation is showing the data because it doesn't translate well to slides. However, this big block of text here is just a very everyday example of what we observed while we were on these wards, stood with a pen and paper, just observing everyday care. And I've highlighted the important bits. And what's key in this extract is it shows that the woman in bed 7, I know referring to people by a bed number is not considered best practice, but we were using the sort of reality of the wards and the language that we heard. We see that she's able to get up and get out of bed and move around. She's able to tidy up around herself. She's able to walk to the bathroom and knows where it is. and she's described as independent and being able to leave her in there for a bit. So why, if a person knows where the bathroom is, knows when they need to go to the toilet, and is able to do so by themselves, why is she wearing a continence pad? Now, it's these continence pads that I'm going to talk to you about today. And continence pads might seem a funny thing to talk about. They're a fairly innocuous, seemingly benign technology for managing waste. And when you're in an NHS hospital ward, you see them everywhere. They're piled up on trolleys, there's cupboards full of them, there's boxes, there's individual pads. The only thing you might see more of is another continence technology, and that's the bottle, the cardboard tube that gets placed next to men's beds for them to go to the toilet in. But what we saw, and the main finding from our 180 days of observations, was these pad cultures, that the pads aren't just used for incontinent patients or people who can't get out of bed. They're used all the time. So we're going to describe how the pad transforms from this relatively benign, useful tool and instead becomes something of containment and something that has huge impacts on a patient population. And that's because of the routine use of these pads in the care of people living with dementia, regardless of their mobility, regardless of their continence in their notes, and regardless of their independence and how they were living before they came into a ward. Now, the rationales for using continence pads from nursing staff are fairly straightforward. You hear quite often that they're just in case. Yes, somebody might be able to get to the toilet, but in case they don't, the pad's there to prevent mess, to prevent waste. They also enable wards to work at the expected pace. Staff are under huge pressures to keep up with patient flow and medication rounds and doctors' rounds and paperwork and all the tasks over long 12-hour shifts. And pads enabled them to be able to fit continence care and supporting toileting into the demands of the wards, containing things at the bedside. Ward staff would describe to us how independent continence care, getting people up and taking them to the toilet, could be a heavy burden. This was work you were doing on your own, with high risks of quantifiable events like falls, which reflect very badly on staff and on the ward and have an impact on the patient, in comparison to continence care itself, which isn't recognised. Nurses aren't congratulated or rewarded for delivering good continence care and toilet support. So staff expressed the view that while they wanted to support patients' continence, they didn't believe it was possible to work in ways beyond putting patients into pads. Now, the impact of this was significant because the problem is that once somebody is in a pad, the expectation is that they will use it. And we saw this constantly where people living with dementia were not only expected to wear the pad, but that they could and should use them. And this would lead to us seeing people signalling to a nurse or a care assistant that they needed to go to the toilet, only to be told, it's okay, you're in a pad. Or agency staff telling nurses that they've taken patients from beds 1 and 2 to the toilet, only for the response to be, why, we've put them in a pad. So yes, the pad is there just in case, but it swiftly moves from just in case to being the case, that people should be able to sit in their bedside chair or lie in their bed and fill the pad, which can be very unusual, especially for somebody who is otherwise continent, because wearing a pad and wetting it or soiling it is something most people won't have done since they were children. So it has a huge impact on dignity. So not just on the individual who then has to sit there in an uncomfortable wet pad until a nurse or a care assistant has the time to come and change them, the dignity of the smells that come with it, because yes, they can contain the material in them, but they don't control the smells. And the fact that everybody can see these, because for older patients, particularly those in dementia, when they're put in the pad, which is always the biggest, bulkiest wraparound nappy style pad because they're the cheapest and the most effective at containing waste, the staff will no longer put people into their own pyjamas because that prevents access to the pad and it's hard to get things up over them. So then you get the hospital robe with the slit at the back, so everybody else on the ward can see the person is wearing the pad, and with it becomes the assumption that that person is incontinent, which is hugely stigmatizing and diminishing to that person. So at home, they could be an independent older person with early stage dementia who's come in with an infection or following a fall, and suddenly they're a frail dementia patient shuffling around in a robe with this very visible pad, all of which is hugely stigmatizing. And it has an impact on their dependence, because continence becomes transformed from an independent action, something that our bodies prompt us to do when we get up and go and do, to a retrospective action. People become dependent on the nurses who, at the times the ward allows, will come to check pads and change pads. And that's what you hear constantly through the wards. I've come to check your pad. I'm going to go and do the pad round. And over the course of an admission, this can be hugely detrimental and can actually develop incontinence in patients that were formerly continent. A big issue around this becomes consent. It's been said before in research into care homes that to put someone into a pad that doesn't need one is a coercive act. And what we saw in hospitals is people are often put into pads without any consent or explanation. They're always just referred to as pads, never as continence pads. The need is never explained. People will often wake up in hospital to find themselves wearing a pad, or they will regain capacity and lucidness because an infection is cleared up, to find themselves in the pad, and they'll be very embarrassed about why. So why are they wearing this thing that they don't need, that they haven't consented to, and the nurse is now telling them that they can't stand up from their chair and to sit down and to use the pad. Now, this obviously causes distress. On multiple levels. Using the pad is embarrassing, wearing the pad is stigmatized and embarrassing, and having to have the pad cleaned is also something that we're not used to. It's, for most of us, it's a process we won't have been through outside of childhood or following incapacitation of some kind. And what we also found is that it's not explained what is going on. So if we're going to expect that patients are having to use the pad, then that pad needs to be cleaned, removed, changed, which involves a very significant amount of intimate care from strangers, which the person doesn't consent to and is never properly explained. The nurse will say, I'm here to change your pad, I'm here to check your pad, but they won't explain that that means prolonged contact with very intimate areas. And the response to this, to being told to sit or to the cleaning or to everything else, is often agitation. There's often some aggression or lashing out, which then becomes challenging behaviour, which reclassifies the patient. They're now resisting care, which has a huge impact on their care while they remain in the hospital and in their care pathways afterwards. If somebody is resisting care and aggressive, can they go back home, or do they need to go into a care home? So we see how pads and gowns really take away someone's personhood, reclassify them to being the person living with dementia. But then this also spreads across wards. It's not just the people with dementia. If you have wards tend to cohort older patients together, and very quickly the diagnosis of dementia disappears and everybody is looked after in the same way. So suddenly you have a whole load of older patients, regardless of their diagnosis, wearing pads with an expectation of high dependence. And with this comes a reclassification of actions. So no longer can patients get up to walk around, because that's wandering, and the risk of absconding and falls. Everything becomes medicalised and is more to the priorities of the hospital, to the minimisation of fall risk, to the minimisation of patients leaving the ward, even though these patients may very well be able to leave the ward, and the reason they might want to leave the ward is because they really want to go to the toilet. Now, what we're describing to you here doesn't necessarily represent a deliberate malicious act or poor care on the part of ward staff. The anxiety of falling behind with the ward shifts and the demands of the ward across a shift is incredibly high, and there were simply no indications that continence care was recognised by institutions as critical for care quality. In a lot of newer build hospitals that we saw, you would have lots of toilets. Toilets were there, so the organisation might say, well, we've put these things here, but they weren't being used, and that's because to the organisation, to the hospitals, what was visible was when things went wrong, when we have risks, when you have falls, but not when things are going right. So good continence care was just not recognised as important for within the care of people living with dementia. We're trying to change this. So in response, we're speaking to policymakers. We're doing a lot of work with the Welsh Assembly presently to try and make this a priority, to make it be recognised. We're doing capacity building with nurses training via our MSc in Dementia Studies at the Geller Institute of Ageing and Memory, and we're building an online tool to promote better continence care and to help support nurses and care assistants in delivering it. And we're trying to create a cultural shift. So we're establishing a community of practice with Public Health Wales. And over 12 months, we'll be trying to have pilot wards to support actual change and interventions across hospitals. So thank you very much for listening to my presentation. If you have any questions, do email me at andynorthcott@uwl.ac.uk. You can follow me and the work of the Geller Institute of Aging and Memory on Twitter, and our book, Wandering the Wards, which goes much more in depth into what our experiences of observing care for people living with dementia in hospitals, and that's available free from Routledge and Amazon in ebook form. Thank you very much for your time.